Hello, everyone, and welcome to our July 2024 edition of our free home health Q&A. We're so excited that everyone's here and how many people signed up for our summer edition of our Q&A. And I picked this image on purpose because I think many of us are in a sweltering heat wave, kind of perpetual right now. And that's its own challenge in home health. And Cindy, I wanted to check on you. I know you're in Southern Georgia.
Well, what always amazed me is the older adults that would always argue that if they kept the windows closed and the shades pulled and the air off, it was perfectly comfortably cool inside. It's like, oh my gosh, no, it is so not. I can still envision one particular patient that I will never forget, always set it up that way and was always wearing long pants and a long sleeve shirt in the middle of summer and swore that this was the coolest way to go. Ugh.
Maybe they looked cool, but they were not cool. And Cindy, I
Oh, no.
talked about my slick move. Those of you that know me, I'm a larger person, and I can't get away with a whole lot of physical things. But one thing I always got away with was turning the air conditioner on when I went into the house, and then always reminding myself to turn the air conditioner off as I left. Because when you walk into a house and it's already 88 degrees inside the house, and then you see a floor heater that's being deployed, those of us that only want to change their clothes twice a day versus 4 times a day because you've sweat through them will figure out ways to get cooler for sure. And mine was probably a little underhanded, but it was survival of the fittest out there. And we used to always, just as a reminder, this is a great time that you can show some appreciation to your employees and to your staff by meeting them on a corner with an ice cream, or meeting them on a corner with a cold beverage, or a frozen, even better, a frozen beverage. Those little things like that can sometimes make folks really happy when they're out running the streets. And maybe one day we'll have a pull along bathroom that's very clean to take with us for those stops. Cindy, what do you think about that?
That would be interesting.
Okay, we better get started because we have a ton of questions this month. Very surprising, and a lot of you guys might come to this session and think, oh, they're going to talk about the proposed rule. Interestingly enough, we received 0 questions on the proposed rule. We do have some information that we want to share at the end, but no questions on the proposed rule thus far because I think there's enough other things going on. But we are in the middle of a comment period, and we will reiterate that at the end to make sure to remind everybody to put their comments in, encourage their staff to comment, and also to encourage their patients to comment about what home health means to them and what some of the changes that are proposed mean to the care that they receive. So we will talk about that, but it didn't seem to be something that was on everybody's mind. And what I wanted to start with today, Cindy, if you're okay, is a couple of questions that we got at the end of last session that we did not get.
Okay.
Okay, if I start to cough, I'm going to mute myself. So I apologize ahead of time. I still have a little bit of a ticky-tack cough. And I think a lot of people are going through this at the moment as well. And somebody just told me that they can barely hear me, Cindy. So I'm going to adjust my volume.
No, Sherry, now we can't hear you at all. Hold on.
I made you host, Cindy, and you have to unmute me. This is a lot of power that is in your hands right now.
So you adjusting the volume made that happen? That's
I think
interesting.
so. I'm not sure, but either way, we're going to get going, and hopefully I can keep my volume unmuted throughout the process. Okay, so starting with questions from the chat box. Can LPNs, CODAs, PTAs take orders? Are you indicating that they can't take a verbal order from a physician directly?
Well, I'm going to defer to the PTA. Go for it, Sherry.
Okay, an LPN, by all accounts, can absolutely take a verbal order from a physician, and they can call from the house just like an RN can and take verbal orders. They need to be in communication with their supervising RN if there's a change to the plan of care, because obviously they cannot do that. However, if they need to change a medication or change a dressing or something along those lines, a verbal order is absolutely appropriate for an LPN. And a lot of places have what's called a VPN. I'm not as familiar with that, but most of the rules of them and an LPN are the same, right, Cindy?
Mm-hmm.
Okay, so for CODAs, which are certified occupational therapy assistants, and PTAs, which are physical therapist assistants, my knowledge in Florida, I'll just make that thing, is that CODAs and PTAs can only take orders from their supervising clinician, meaning that a CODA can only take an order from an OT and a PTA can only take an order from a PT. This is in the State Practice Act, and I always urge everybody to look at your State Practice Act. But when you have that caveat that they can only take it from their supervising clinician, they cannot reach out to a physician and take a verbal order. So that's something that is pretty clear as a PTA. That's pretty clear in my license in Florida. So I always recommend that you go to your State Practice Act and review that to be sure. But generally, I've never heard that be different. Cindy, have you heard that be different in other states?
I have not, but I can't say that I routinely read all 50 practice acts on a regular basis. So this is a great example of a question that whenever you're seeking an opinion, it does need to be vetted against your state-specific rules. Also, I would strongly encourage, if you have a state where it isn't really specific about it, it doesn't land one way or the other, that you're very careful about any policies or procedures that you write related to this. Because you want to make sure that there's a clear procedure of how this should be handled, who should be communicated with, those kinds of things, because you don't want to leave it open-ended and then potentially have a surveyor come in and choose to have a different interpretation and potentially run into issues. So this is where, from a federal standpoint down to that state level, we have to make sure that we're covering all the bases.
Right. And I think that it's super clear in this Florida State Practice Act that you don't want to write, and I'm going to echo what Cindy said, you do not want to write a policy at your agency level that is more stringent than what's at your state level or what's at your federal level. So the federal level, to my knowledge, does not address who can and cannot sign or request a verbal order. State does in the state practice acts of each individual. So definitely pay attention to that. And the next one is sort of a kind of along the same lines as far as what OTs and PTAs can and cannot do. So this is question number 2. If a PTA or an OTA are the last discipline, and then the PTA are the last discipline in, and then the patient is DC'd because of refusal moving out of the area, can the PT OT collaborate with the assistant and complete the OASIS DC assessment, or should it be the last qualified clinician to visit? Cindy, as someone who sleeps with the regulations under your pillow, you're up.
So the issue here is that if we are unable to make an additional visit to that patient's home, and the reasons given were they refuse, move out of the area or whatever, the responsibility falls to personally to the last individual of a qualified discipline to complete the OASIS, their last visit. So the wording of the question is, well, if it was, let's just say it's a PTA made the last visit, can they just talk PT and a PT fills out the form? Worded that way, no. It would have to be a PT that has seen this patient, and that information would be primarily driven then by what that PT saw when they were physically with the patient. Now, can they collaborate with that PTA or others that may know more about this patient? Yes, but it has to be a person who has physically seen this patient from a discipline considered qualified to complete an OASIS. So again, it can't just be, if it was a PTA, they can talk to any old PT and then use this to write the form up. That you cannot do.
And I like the term qualified because it's super important as we go along that you understand that the qualifying disciplines right now are nursing, physical therapy, speech therapy. OT is a qualifying discipline on the research, but they are not a qualifying discipline on the start of care. Is that a fair statement, Cindy?
Correct. So in that scenario, we're talking about something happening at the time of discharge. So it could be that the very last visit was done by an OTA and that occupational therapy is the only remaining service. That's perfectly fine. They're just the last ones to finish it. But again, it would fall to the OT that made the last visit to that home.
Yes.
Now, I want to clarify one other piece in that, though. Now we're assuming a bit the way it's described that that's the only service left. The other thing we have to keep in mind is if that last visit, physical visit to the home was done by a PTA and 2 days prior, nursing had made a visit, they would be considered the last qualified discipline in that home. So whenever we're dealing with this situation, and I have a feeling, Sherry, this whole, we missed a research, somebody won't let us come back, odd things around discharges or ending up in a facility is kind of a theme of the questions we've gotten for today. This is why it is so important that these situations are a rarity. And that we try very hard, especially when it's, and I got several of these questions outside of the Q&A cycle this time, Sherry, about, well, the patient won't let anybody come back. I think we need to be careful. There seems to be an uptick in that. And I do think, just being candid, I think staffing is playing a role in that. The patient doesn't want to be seen. Okay, good. Then we can go see somebody else and we'll just take care of this. I think patients are more reasonable than sometimes we give them credit for, and we really need to explain it is important that we come back to wrap up this assessment to provide the appropriate information that Medicare is looking for. I find it hard to believe that I've just seen this upswing in nobody's letting us come back for one more visit to discharge. This really should be an anomaly. So that's a bit of a preemptive strike, Sherry, on some of the other questions I know that are on your list that kind of all fall into this. We missed something because it's just interesting to me to see so many of them come in the group for this particular Q&A.
100%. And I think that it's super enlightening that they're all coming out at the same time when we have an audit that's happening where they're denying payment based on timeliness. So I think that that's one of our questions today and one of our things that we want to discuss. But I think that timeliness is they're related to one another for sure. And why we have that kind of dialogue going on. Thank you for that, Cindy. Number 3, everybody ready? Here we go. Are physician protocols allowed in home health? If so, can a physician protocol include a set frequency for all patients from that referral source?
Now, this seems like a very straightforward question. I'm sure people read it and went, are physician protocols allowed in home health? Yes. Okay, move on. But I can tell you from my interactions around this particular question, we have to be careful because if we're thinking about physician protocols, then that is a physician generated or physician collaborated with protocol driving the care decisions for a particular population of patients. So they may do it by certain diagnosis groups, then in terms of what disciplines they want included. In my previous life, we would develop protocols with physicians around congestive heart failure and what disciplines we thought and what frequency and that kind of thing. But it very much needs to be clinically driven and either driven by or collaborated with that physician. The second statement of that question is where things, when I pursued that further, got a little hairy, because what is concerning is an idea that a physician protocol is me telling the physician what the frequency and duration is going to be on their patients. Because that doesn't sound protocolish to me. It sounds like what we just touched on, Sherry, an attempt to manage difficult staffing situations. So I think that if it's a conversation with the physician and we talk through what the needs of their patients are and how we can best meet them, I think we're okay. If it is, I'm just going to tell this physician in this practice that he gets nursing once a week and PT twice a week, and that's our protocol, that doesn't feel a protocol to me. What do you think about that, Sherry?
Well, I like the ideas of standing orders, right? I like the ideas that, we in home health, we have to set standing orders as far as what we think the blood pressure parameters should be, the heart rate parameters, all of that should be in your clinical operations manual. All of that probably needs to be signed off on by your medical director. If you don't currently have a medical director, that's okay. But this would be one of the uses of a medical director for billable time for them. To sign off on your protocols or your quote unquote standing orders. I can see it being super useful for PTI&R med changes, for wound care changes in certain situations, and obviously your ortho patients and the protocols that those physicians might have. I get a little bit worried about the uniformity and the lack of individuality in a standing order. I think that sometimes if it specifically matches that, that's great. But if you have a standing order that says A plus B plus C plus D, and you go A plus they don't need B, C is A, and I'm going to do D. So I'm only going to do A and D on the protocol. That completely breaks the protocol. Is that a fair statement, Cindy?
Yes, but
And
I
that's
think that, I
that's
mean,
going to
you're right, but
require
you're
additional orders, is what I'm saying. So
correct.
I'm not sure what kind of a time saver it would be in that regard. So
I mean, yes, I think protocols can be a great way to streamline care. I see a lot of them still around, especially from orthopedic physicians, about, you know, what they want done after the procedure, and it's procedure driven. All of that's fine. I'm just wanted to kind of put that caution out there, Sherry, when it went straight to a set frequency for all patients from that referral source. We have to be careful there.
yes.
Because is that really driven by the individual needs of that patient, or are we trying to triage from a staffing situation? And I'm not downplaying any at all about some of the severity of the current staffing situation. But I think it's imperative, particularly when, you know, there's touches of it in the proposed rule related to timely initiation of care. We have to keep the lines between what patients need and what we can provide very clear.
Mhm.
Because sometimes we're making the best of a bad situation, but I've seen it time and time again where people will tell me, I'm doing what the patient needs. And you look at it and say, so you only have a speech pathologist Tuesday and Thursday. So you're telling me no patient you ever have that has speech therapy needs ever needs more than twice a week. And if they can't do it on Tuesday or Thursday, once a week is adequate. Yeah, you have to be clear. Yes, this is what I have. This is what I'm working with. This is how we're trying to manage it. This is what we need to do about how we're working towards staffing it. But I think we need to be very clear that somehow that morphing into best practice is a bit dangerous.
100%. And I just want to caution folks for that uniformity, caution folks with that. You got to look at the motive for going into the standing orders. And there are some really challenging diagnoses that we deal with in home health. I think about CHF. I think about the weight gain protocols and when they take their Lasix and all that kind of stuff that, you know, I say Lasix, furosemide, whatever the other medications are. And that's super important that we keep that as specific as possible. And if you're going to have a protocol, have if this, then this type things. Have a drop to have a Cindy, you do these all the time in slide decks and what is it? The decision tree? Have the decision tree, if this, then this, if this, then this. That saves you a little bit more time and not having to go back and forth to the physician for changes. So that answers that question. Okay. Yes, you can have standing orders, but proceed with caution. Okay. All right. So we put together a survey. It is July. It is mid-year, and this survey is a question about conferences, what kind of conferences you're attending, what kind of conferences you're looking for, what is the thoughts out there in the universe of home health about where you're receiving your education. We know resources are thin. We know staffing is hard, but we also know that the education is important and the training is important. So take literally this survey that we have here will take you 2 minutes to complete. So if you could give us that information, that helps us to provide the things that you need in the way that you need them. So thank you so much for those of you that will participate in this survey. I want to go on to question 4. Are you ready, Cindy?
Yep.
Okay. I'm going to actually reclaim host and then allow you to unmute yourself. Okay, Cindy?
Okay.
Okay. All right. For Pacific, I almost did it. For specific wound care supplies, should this be reflected on a client's med list? Mepilex, MetaHoney. What about creams, lotions that are being used, Aquifer, Eucerin? We do reflect the aforementioned in an other order that the MD signs off on, but should this be on the med list that's on the POC?
I'm curious, as a former agency owner, what your thoughts are on this as well, Sherry, because I mean, to me, a medication list is supposed to include topical medication. And you want to get as complete of a picture as possible. So anything related to wound care supplies from a prescription standpoint, I would see it on there, and the dressing pieces potentially separated out from that. But I understand, I mean, one of the biggest challenges we've had is accurately reporting supplies as well, despite the fact we don't necessarily get directly paid for those kinds of things. Listing those things on the claim is expensive, is a piece of that. So what are your thoughts, Sherry?
I agree, Cindy. If it's a physician ordered topical, yes. If it's an
Mhm.
over the counter topical, I put it in the same category as I do multivitamins. Do you list multivitamins on your medication list? Most do. So I think that using those topicals in the event of a wound treatment is important. And as someone just put in the comment list, and I agree with you, the Joint Commission surveyor, that they should confirm that they should be included on the med list.
Mhm.
And so I think that that's probably great advice, and something that's going to keep you more abreast of what's going on with that patient, especially with their skincare. And so I think yes, my opinion is yes. Do I know of a regulation that stipulates that it must be? No, I don't know that regulation. Cindy, do you?
I look at it and say, you want to complete as complete of a record as possible. So especially in light of the person who commented that Joint Commission confirmed that they want it on there. I think I would rather be in a situation of it's on there. I have a one-stop shop of a complete picture of the patient and somebody say, you know, it didn't really need to be, than leaving it off and having someone say, where is it? So I would err on the side of as complete a picture as possible from a prescription viewpoint to get it all on there. And I would think that was a safer position than risking it just not be.
And I think that using the patient as part of that care planning at your recertification or at your reassessment, having that list available for the patient to review to say whether or not they're still using those items, I think is another technique that you can use, or another tactic you can use to get the patient involved in what's going on in that med list. And what they're using and what continuing to use over the counter and what they're not continuing to use over the counter. I think that anything that can get the patient engaged and get them involved in what you're reporting, I think is so important in this situation too. Okay, here we go. Moving on. All right, number 5. The nurse sent the patient to the ER during what would have been the recertification visit during the 5-day window. The patient was in observation status for several days. Everybody, a collective groan over that word, observation. Okay. They were admitted for several days, and then they were admitted to short-term rehab in the new cert period. Does the recertification OASIS need to be completed, or should we complete the transfer, discharge from services, and complete a new start of care when the patient returns home? Cindy, this is all you.
Okay, big picture. This is another example of why, even when some of the comment periods are not home health exclusive, when there's discussions in other post-acute settings about this observation status problem, we need to make sure we're making our voices heard. That right there, the way that the hospital can utilize observation status to basically camouflage hospital admissions has multiple consequences in the post-acute space. Because realistically, had this person gone ER and been appropriately admitted to the hospital, especially there for several days, then we know absolutely this would have been a transfer, and it could have been open-ended without the discharge, or discharge depending on what the agency wanted to do with that. Observation status blows it up here. Observation blows it up still for people that are trying to go from a hospital to a skilled nursing facility, only to find out they were never admitted. And now we run into issues of who's going to pay for what. So anytime you see blasts or discussions about an open comment period connected to dealing with observation status, we need to jump right on there, because this is the consequences we face. Because you can't change the fact that this person was technically not admitted to an inpatient facility in that time frame. So the transfer couldn't have been done in that 5-day window because they technically were not admitted. Then we see the calendar lapse. Now they are admitted. So I did some digging, and there's those wonderful attempts CMS makes when anybody asks questions like these about, especially if it's a missed recert, then you should do the recert late, as soon as possible into the next cert period. I understand that if it's a situation where we missed it or something happened scheduling wise, but that's not what this is. This is someone is now in a facility, and we don't know for how long they're going to be in this rehab facility. So when you look at it that way, one, I think this is a great question to be officially submitted in the Q&A box to CMS, because I'd love to hear what they have to say in relation to that observation status wrinkle in this example. But based on what we know today, I can't do a recert. I would do a recert and then they're gone. I didn't do a recert assessment because I sent them to the hospital. Now, technically, could you say, well, they did make a visit, they did assess the patient. I'd be curious why, if that visit occurred in the 5-day window, why it wasn't done as a recertification. Potentially that could have been. So if you think about it, and Sherry, jump in if I'm either not making sense or confusing people. If you look at the way this question is worded, the nurse sent the patient to the ER during what would have been the recertification visit. So that nurse was in the home, assessed the patient, sent them to the ER. A recertification could still have been done based on the fact that that is a qualified discipline, nursing, physically in the home in that 5-day window. So you look at this and say, if you peel this very specific onion, the recert could have been done off of that visit to establish that you intended to see this patient in good faith. You thought, they're going to go to the ER, but they probably are going to come back to you. And then when they were transferred to the rehab, done a transfer to the inpatient facility in the new cert period. So I think we're kind of stuck in we missed a recert. Is there enough information by that nurse who ended up sending that patient to the ER to create a recertification that is late, but based off that visit, and then a transfer either with or without discharge? But again, if someone knows something more current from CMS than I do and has a resource for that, or if we want to put a pin in this one, submit it officially to the Q&A cycle and see what happens there. But I think the question, observation status is what makes this confusing, but I would question why that visit to the home in that 5-day window, although it did send the patient to the ER, was not done as a recert.
And Cindy, I have tagged this one for us to put in possibly as a question for the Q&A and a statement during the comment period while they're setting our proposed rules, that they can't, just because they maybe didn't mention an observation specifically in the proposed rule, they can't skirt this issue and keep throwing it onto us as being the responsible party. I have I have two angels, a good and a bad angel. One of the things that you being a home health agency owner in the past, it shows you how people like to, what's the word I'm looking for? Manipulate the rules sometimes. And one of the things that jumped off the page at me is, do we do a transfer to discharge or a transfer to the hospital? And obviously, a transfer to the hospital would be the appropriate document, most likely, if you didn't do this as a recertification. Transfer to discharge would enable the agency to not have to claim an unplanned hospitalization. Is this a fair statement, Cindy? If I'm going way off the rails, please tell me. So I think that you need to think about all the things that this could look like in the end. And that is probably, that complication is what makes it a great question, because they're not going to capture the data that they want by the transfer to discharge. They won't know that the patient went back to the hospital during your care. And that's what CMS wants to know. Even if it's not your fault, they still want to know if that's occurring. That's part of the data that they collect for home health value-based purchasing. It feels to me that the way that makes more sense to me business-wise would be to do the transfer to the hospital or the recertification with the transfer, maybe even on the same day, and have that person still be under your notice of admission, so that if they leave that skilled nursing facility within the next 60 days, you would be notified. Otherwise, you may also lose that patient. Have I just made this worse, Cindy?
Well, no, I just think, the piece that, again, as everyone knows, when we're looking at these Q&As that are entered, there's no way to ask a next generation question of the individual who submitted it. which is why I know Sherry says, go ahead and ask your question in the chat box if you have one while we're doing this, because then there can sometimes be a dialogue with the person who's asking. We have to go strictly off what's being written in the question. And I go back to, I'm just not understanding why the nurse was in the home, did a full assessment of the patient, sent them to the ER, why the recertification was just not done. Because had that been done, yes, you'd still run into the observation status issue that you could not transfer them anywhere, but then they ultimately went to rehab. So you could do a transfer, either one of your choice, but the chain of events would be there. Now there's two elements. Yes, observation status caused the problem, but I question why the research wasn't done. And I think at times we have to instill in our clinicians the importance of every item, every time point, every time. I know the start of care, you can't really, dodge that one. That's on your schedule. You need to go do it. But sometimes these other ones, the kind of, well, I sent him to the ER, didn't have to do it. Oh, the patient doesn't want me to come back anymore. Those kinds of things. OASIS data only works correctly in most cases when it's a bookend. From a quality measure, from value-based purchasing, all of it is they need a beginning and an end. And I think sometimes we're getting a little loosey-goosey on the end. And I think the clinicians need to be reminded that it's important you get accurate data collection, and you needed to have done that on that visit
I agree.
to the
And
best of your
Sharon
ability.
put a comment in our chat box. It says, I would advise the clinician to complete a transfer with DC and date M0906, the date of the last of the cert period, the last date of the cert period. Answer that the patient used the ER without hospitalization and was admitted to SAR.
Yeah, I mean, this particular situation requires significant paper trail.
Yeah.
Because if this one got pulled for an audit, if a surveyor grabbed something, I mean, you would want to make it very clear this was the actual chain of events, because from, the CMS data side, the observation thing throws it off. So yes, the recommendation of documenting all the steps that were taken is important.
Okay, thank you so much for that statement, Sharon. Appreciate the participation. That is awesome. Okay, question number 6, y'all. We got a lot to get to, so I apologize if we're flying through, but here we go. Since C1310, signs and symptoms of delirium, is supposed to be completed after completing the BIMS, if you aren't able to complete the BIMS for some reason, should you still complete C1310? The guidance states that you can also review the medical record.
Okay, so the BIMS and C1310, signs and symptoms of delirium, are not conjoined twins. The recommendation at the beginning of C1310 was really a convenience issue, because a lot of what would happen doing the BIMS would give you some insights into 1310. So I am not required to have done the BIMS to answer 1310. You are correct that there's different ways I could get that information. My concern in the question is if you aren't able to complete the BIMS for some reason. I just want to reiterate that the only time that you can utilize a no response to the BIMS is when the patient is unable to be understood. So no matter how I try, they tried in writing, we tried pictures, we tried an interpreter, we tried all of it. I cannot reasonably understand what they're telling me. So if you think about it, if that's the situation they're in, it would be unfair to attempt the BIMS because I can't figure out what they're trying to tell me. So that is the only time for no. I still see no for I ran out of time. No, the patient didn't want to do it. No, the patient didn't need to do it. You can't do that. No is exclusively for rarely or never understood. If I have a patient who is refusing, okay, then I still put yes to do it. And then we follow the official guidance about the response options we're to choose. And we're going to end up with a score of 9.9, which means we don't have a total score. And you would have the response options more often than not to say the patient didn't respond or didn't, decline to respond, whatever. You have all your options there. In that situation, I can have somebody who flat out refuses to do the BIMS, and I have to make sure I put yes and I answer those questions because I understood them because they refused. They were very clear about it, so I can't say I didn't understand, but that doesn't mean I can't do 1310. I can still do 1310 even in a patient refusal situation. I just wanted to make sure that we continue to nip in the bud the improper use of no, Because anytime you put a no, CMS views that through the lens of, okay, that means you couldn't understand this person. So the rest of your assessment should reflect something along those lines. And so on our outsourced servicing side, we still see where there's a no, and then the patient apparently could answer every other question you asked them, just not the BIMS. Well, that doesn't make any sense. So we just want to make sure the BIMS is being reported accurately. And regardless of what happens with the BIMS, you can answer 1310 independently of that.
Very well said, Cindy. Okay, number 7. We're going to get to as many of these questions as we can, guys. Non-visit discharge OASIS. Section A, which would be the most appropriate response? Unable to respond or declines to respond, especially if using medical record documentation is not an audit or not an option.
Well, there's a reason that we end up in these situations. It's because we're not supposed to be doing non-visit OASIS discharges. I understand that some EMRs have generated them, but they really should only be in case of emergency, break glass, vet all other options. Because the reason the discharge OASIS is worded the way it is the expectation is an in-person visit with this patient by the qualified discipline to get accurate information. They're not designing it with an eye toward, here's how you do one if you don't do a visit, because they don't want us to do it that way. This should really be, okay, I've tried everything. I know I can't go kick the door in. They didn't tell me they were going to move and they moved and I can't, yes, I understand. So in that situation, and only those extreme situations, should we be dealing with a non-OASIS discharge. And we know what the directions are overarching in terms of the last qualified discipline person that was in the home. But in looking at Section A, when we're talking about interview questions, I mean, you got to kind of look at it and say, all right, I didn't even ask them the question. They're gone. They're not accessible to me. So from my perspective, unable to respond is more accurate than declined. But again, I've done some digging. I don't really see a hard and fast decision. I think CMS always answers these questions with, you shouldn't be doing that. But I think it's one of those where documentation is going to need to be clear of why this occurred. This was a situation we were in. And if I'm dealing with questions and I don't have the patient in front of me and clearly there's no proxy, and sometimes I can use the medical record, but sometimes I can't, then, I mean, you could argue in a case where the patient has absolutely refused another visit that they are declining to respond. I mean, I think it would depend on the situation and how well you knew the patient before that, but it's really not something that should be occurring with any regularity, and why these questions are not built to accommodate a non-visit discharge.
That makes complete sense. Any comments that you have on that, please use the or any questions that arise from anything that we're talking about today, please use the chat box. We will be trying to bring any chat questions forward to the next Q&A if we don't get to them today. So this next question is long-winded. Cindy, are you ready?
I'm ready.
Okay. We are getting pressure to add nursing to every start of care which has a diagnosis that drops into the MMTA clinical grouper. Example, COPD and CHF. I've read the COPs, IGs, Chapter 7, LCDs, and a home care billing directive provided by Palmetto, none of which states that MMTA cases must have skilled nursing involved. Common sense indicates nursing will be involved in the vast majority. Are you aware of CMS Palmetto guidance, including MMTA cases where nursing must have nursing involved, or that a case cannot be billed if there does not have nursing involved? Are you aware of any audits focused on this issue?
No, no, and no. There is nothing that requires nursing to be involved in MMTA. I can tell you, as someone who was back in one of the OG technical expert panels when they were building this whole thing related to PDGM, I was very vocal and said, please reconsider what you're naming these. The neuro rehab, the musculoskeletal rehab, and then this nursing one, create this idea that there's certain disciplines that have to be a certain way for these. And, oh, no, that's not what we mean. We've explained it. Well, you sort of have and you sort of have not. But there is nothing that requires nursing to be involved if this person ends up in the MMTA clinical group. Or as a matter of fact, that's still the largest group people end up in. They made, the little groups and then said, everybody else goes here. There's no requirement for that at all. So no, there's no auditing to my knowledge around this. And the reason I do very much appreciate that the question asker vetted all of those sources. There's also times that when you've checked the COPs, the IGs, Chapter 7, LCD, and billing directive and find nothing, what that means is there is no restriction. There is no requirement. There is no rule that says that.
And we should not ask for additional rules, right, Cindy?
No, but I also think if you run into that situation of anything bigger than just the one question, but anything where someone's saying this is a rule and you've gone to every source and cannot find it, and you present that back that you're not finding it, and this person or group still says it's a rule, I would not spend additional energy on your side trying to find it. I would put the ball in their court and say, okay, we've checked all of this, it's not there. Please go find me your source. I'm happy to do this, but I need to see the source of your information. Sometimes, Sherry, that's what I've had to do when it's like, I still know it's a rule. It's not. We've looked everywhere. It's not, but I know it is. Well, then you need to find the source for that, because I'm not going to keep digging up trying to find something that appears to clearly not exist.
Right. And it's okay that they haven't written us a rule for every single possible thing. They do allow you the art of practicing what you do. And as long as you're not completely breaking a rule, you normally can, as long as you pay attention to what you're doing, why you're doing it, document it well, you should be okay in the event that there's not a rule that's spelled out for you. Fair statement.
Yep.
Okay. So this next one is a question that apparently was yelled at me. I don't know about you, Cindy, but when I get texts and things in all caps, I always think somebody's yelling at me. But if I had gotten a denial for this reason, I would have done it in all caps as well. Okay, so I do not blame this person that submitted this question at all for the increased emotion. Have you any insight that what is triggering the increase in RAC audits documentation requests? Performant has denied entire episodes of care if there is not a separate signed order from the MD provided for a delay in the start of care, resumption of care more than 48 hours. Will not accept a case communication note with the MD and the EMR. Not sure yet if they will accept as the delay in start of care order the new date added to the start of care plan of care 485 statement start of care for my home care. What is going on, Cindy?
Okay, so we know that there are expectations in the conditions of participation with respect to timely initiation of care, that we are to be out there within 48 hours of receipt of a referral or on a established physician ordered start of care date. We see this mirrored in the OASIS because we have two questions that relate to referral and a different one of the other two that is about the start of care. This is a compliance issue with the conditions of participation.
Yes.
It appears that we are now seeing it being misconstrued as a billing payment issue. And some of you may be nodding, although we can't see you, because you've seen the traffic on this from entities like the National Association of Home Care, who has been diligently communicating with CMS and has had CMS confirm this is not a condition for payment. This is not a reason for denial. And people are still seeing it happen. And the advice is, well, appeal because you'll be successful. Okay, but it still takes time and dime to deal with the appeals related to something that is inaccurate. I would strongly encourage individuals that are experiencing this to continue to take this to Mary Carr, C-A-R-R, at NAC. She's been spearheading, reminding CMS that, yes, you've said it's not a billing issue, but you still got your people doing it. Your intermediaries are still trying to deny people over this. It just popped in my head, Sherry, that people might want to consider with the open comment period on the proposed rule of planting some seeds in that as well. Although there isn't a thing about it in there, there are lots of payment related things in there. Maybe an opportunity to remind them of this, but technically speaking, we cannot be denied payment over the timely initiation of care. But I want to caution something, because although it's not a payment issue, we're seeing a lot more of the start of care dates moving around in relation to, again, what appears to be staffing concerns. Now, although we cannot be denied payment, I cannot just move dates around without the appropriate physician involvement and the paper trail. So I know in my past life, I dealt with my rehab team, and it was like, they knew if they got an admission scheduled for Friday, there was a chance this person wasn't going to want to do it. They were going to be, I'm tired, I don't want to do this, can we do it next week? Okay, I can't just say the patient requested Monday. I still need to contact the physician, let them know that the admission plan for today is not going to occur until Monday, and are you okay with that? I think we get a little cavalier that the doctor doesn't care and the patient doesn't really care. You haven't seen this patient yet. You don't know what's really wrong with them. And you may encounter a physician who says, no, Monday's too long. Somebody's got to go sooner than that.
Mm-hmm.
We have to show the physician is aware that we've moved it. So pushback about it's not good enough in a communication note, it isn't. We have to show an updated order. So if we've moved it and we look at the directions in the OASIS guidance around those two items, it can't be moved just because a family member requested it or a facility did. We have to make sure the physician who's ordering this care is aware. So bottom line, I cannot be denied payment for this, and I need to appeal it and unify with others to make sure this gets put to bed. But at the same time, I absolutely can get nailed on survey if I don't have the appropriate documentation that the physician was engaged in having to move these dates.
And we have a direct message, Cindy, that's told us that one of the fiscal intermediate, or one of the MACs, or excuse me, RAC auditors, Performant, they've been having some success with their appeals with Performant on this, but that there's Regents Med Advantage is denying even after the appeal. What Cindy said about Mary Carr would like to know anybody that's getting a denial on this issue. She's collecting information to add to her quiver, an arrow for her quiver to go to battle on this. And so please keep her in the loop, and her email is available on the NAHC website, nahc.org. And reach out to her directly, let her know what's going on, and walk her through what you're receiving back on your appeals. This is a manpower issue. A lot of times it is or woman power, I should say, since the majority of people on this call are women. Women power issue as far as having the FTEs to take care of making all this happen and making sure the documents get to be everywhere. Using a professional that has great success in appeals is a good idea. And at K&K, we do this. We have someone that works with us that we consider to be one of the best in the business. And please don't hesitate to reach out, because you guys are strapped enough. Reach out for some assistance in this situation so that you don't have to get to that third level or fourth level of where you have to go in front of the ALJ, and it just takes too much time, and time is dime, right? So make sure you reach out for assistance on that. Cindy, we ready to move on?
Well, I want to add something to that, because recently it happened to a family member of mine. It happened to a colleague's family member that I became aware of in the last couple of days. In both cases, these family members received orders for home health, were told what agency it was given to, and then didn't hear anything for multiple days. Until once contacted, they were informed that they didn't have the right face-to-face paperwork.
Yep.
I'm sorry, that has a time window before or after the start of care date. The idea, and I understand, because it talks about, a complete referral, but we have to remember we're servicing people. And if there's going to be a delay, they should be made aware of this, because in both cases, mine and the colleague, that family member would have sat for who knows how long waiting for this paperwork issue to be resolved that they were not informed of, and only because they have bossy daughters. Phone calls were made to say, what are you doing? You have 48 hours to get this person started. What's the hang up? Well, we're waiting on an order and we don't have it, and we're not going to start until we get it. So I understand us wanting to make sure we have all our ducks in a row, but I'm a little concerned, and I just want to put it out there that these are people and families that are waiting for services. And yes, maybe if I wait and then my date of referral is this and my other, and I look all timely to CMS, If it's taking a week to even contact them, that's too long.
And Cindy, I'm going to say a very controversial statement before we go on to our next question. And my controversial statement is, I do not remember this being an issue during the era of a wrap.
No, because people were getting admitted right away so that we could collect 50 to 60% of that episodic rate as fast as possible.
Interesting. And CMS sees this as well. So FYI, they're looking at this with a fine tooth comb, and I think that everybody needs to be aware of that and know the full history of how we've been paid in home health, and understand that receipt of anticipated payment went away at the time of PDGM, and all of these issues started springing up afterwards.
Well, and keeping it brief, Sherry, because I know we have time, and it wasn't a question submitted, but anyone who's looked at the proposed rule, we see one direct proposed change to make a adjustment to the COPs to require us to disclose capacity basically and make it publicly available, combined with an RFI, request for information, to better understand why beneficiaries are not being seen timely. So yes, it's incorrect that we're being denied payment over it, but CMS is well aware, and beneficiary advocacy groups are all over this in terms of the stories they're hearing from people not getting care, not getting communicated with. So do I think, making a COP of that policy, does that fix the problem? No. But the RFI is an opportunity to really clarify that there are significant challenges, and how are we better managing them? Because it's between the denial attempts and the proposed rule, you're absolutely right. CMS is all over this. What is it taking so long? And to give context, it's not just home health. They're seeing these delays in getting people admitted to skilled nursing facilities, delays in other elements of the post-acute continuum, and they're not happy because, as you can imagine, especially with the SNF situation, it's increasing length of stay, which is expensive on the hospital side. So I expect to see much more discussion going forward about what's taking so long and leading people to not get services or end up staying in the hospital longer.
Hey, I know a fix, and it's quick, but I don't think it'll happen.
Oh.
Go back to wraps.
Or pay us more. Stop saying we're the least expensive. How come you can't get enough people to get them all starting care, but here's another pay cut?
Yeah.
I mean,
but going back to that receipt of anticipated payment would cure this in a quickness. It would be fun to watch from our perspective. I have to tell you, it'd be fun to watch the needle go to the other side, and then the statement would be, we're admitting too many people too quickly who don't qualify. Anyway, there's all kinds of things that could go around that, but I hope that everybody took the gist that I meant. Okay, so we had several questions come in, Cindy, on maintenance, and I wanted to make sure that we got to a few of them. Okay, number 10, if a patient discharges from restorative therapy and later comes back on service for maintenance, would a new face-to-face be required in this situation?
Okay, the part I want to clarify is later comes back on services. So clearly, if the patient was discharged had restorative therapy, was discharged from the agency, came back later in a brand new episode, and now we're talking about maintenance from the jump, obviously we have to have a new face-to-face because this is a new start of care. I think what was intended by the question is if you switch, so the patient is a home health patient, has been receiving a restorative focus of care, and the decision is made to move to a maintenance approach. You do not need a new face-to-face. This is not changing the fundamental elements of home health in terms of qualifying criteria, coverage criteria, and all that good stuff. It is simply the therapist deciding that the focus is going to be on stabilization, not improvement. Now, it is clear that that kind of a change needs to be documented clearly by the therapist, and an updated order with the plan of care changes involving the physician to be part of this. So if you think about it, I'm making a significant change to my plan of care. And just like any other significant change, the physician needs to be aware we need to have proper updated orders. I would be wanting to change my goals for this person so that they better mirrored maintenance. That's what you would need to do. But I do not need to go and get a whole new face-to-face to be able to do that.
And Cindy, I think that that's a great explanation, and I want to bring people's attention to the QR code that we have on the screen for our maintenance therapy series. The very first session in this series is on sale for $7 because we want y'all to see what the regulations are in that situation. But a lot of these scenarios are worked out during the maintenance therapy series, and this is the updated one that was just completed this year. We've been speaking on this subject since 2013. And we know for sure that a lot of folks that are on this call and a lot of folks in home health are not providing maintenance therapy services or nursing M&E. And it is a benefit that's there for the patient. And Cindy, can you talk a little bit about whether or not it's a required benefit?
It is a required benefit. It was not created in light of the JMO versus Sebelius. It's something that if the patient meets qualifying criteria and coverage criteria under the Medicare Part A home health benefit, yes, they need to be receiving this approach to care.
And question number 11 is an interesting question. It always comes up around maintenance therapy. What is the likelihood we should receive additional documentation requests on maintenance therapy or nursing M&E?
Okay, so realistically, if you look at the volume, and home health is a unique setting because we have a specific G code to put on the claim to clearly indicate physical therapy maintenance, occupational therapy maintenance, and speech therapy maintenance. Other settings don't have, like outpatient doesn't have CPT codes that say maintenance. So the use of maintenance can be tracked through claims data. I think it's grossly underreported, under-acknowledged.
Mm-hmm.
I think the only situations I've seen where people have gotten ADRs is when they've had what's perceived to be a significant amount of maintenance. And that is not a deterrent. In the same breath I said it's underreported, then it says I've seen ADRs on folks that appear to be doing more of it. That's the unfortunate reality. If everybody else does 0 and you do 10, that looks like an anomaly. The reality is everybody's doing some and needs to do a better job of reporting it. The 10 doesn't mean you did something wrong. So we tell folks, and it's definitely evident throughout that series, that your documentation needs to just assume you're going to get an ADR. I'm not saying you automatically do. I wouldn't use that as a panic strategy or this is why we don't do maintenance. I would simply say, you know what, anytime you're doing something different, as a PT colleague of mine used to say, he'd say, you can always tell the pioneers by the arrows sticking out of their back. So I'm going to assume somebody might want to shoot at me. So I'm going to make sure that I'm extremely clear. And if they want to ADR me, here you go. I know exactly what I'm talking about and move on.
Exactly. And I just want to encourage everyone that, or let everyone know that if you significantly change your practice pattern in any way, if all of a sudden you stop doing a certain discipline or you do a certain discipline more times, sometimes that can catch the attention of the reviewers. And once you do an ADR, or once somebody sends an additional documentation request, or if it's uncovered during a TPE that you do have these maintenance therapy cases on, it's just to prove that you're doing what you're supposed to be doing. And literally, if you can pass that on the first try, it's a very insignificant hit to your time crunch. So I don't want everybody to be discouraged because of the possibility of an ADR. That can happen if you change your practice in any other way as well. And that goes for improvements or degradation of your care, of your services. So I think that everybody just needs to be aware as CMS gets better at evaluating the data, this is going to happen more often. Okay, last question. It's a good one. Cindy says she wants it. Do managed care insurance plans follow maintenance or Medicare maintenance guidelines?
Well, the wording is interesting. Does managed care follow guidelines? They try not to. Are they compelled to? Yes, they are. And the Medicare Medicare, what is it? I always mess the name up, Sherry. Judith Stein's group.
Oh, the Medicare advocacy.
Yes. If you go to their website, they have extensive resources regarding the JMO decision and maintenance therapy and very explicit information about managed care's accountability to follow those same rules. So I would never say, well, you have to do it because Cindy Krafft said that thing on a free Q&A. I would go and get those resources from them, the ones that successfully sued CMS in the JMO case, to be able to remind managed care that they cannot deny, refuse, or try to develop different standards around the application of maintenance therapy.
Exactly. My first thought when I saw that question, Cindy, was it depends. It depends on a lot of things. And I think that, you should ask for that authorization when you ask for the authorization on any other kind of visit and explain what it is. And if they deny it at that level, I think using Judith's, the Medicare advocacy group to your benefit and letting them know what's going on is definitely a good thing to do. Cindy, did you have any additional things before we go? Because I put up the last slide with our sweating earth and wanted to let everybody know that our session next time is going to be a week later. My anniversary is actually that normal Thursday that we do. So I'm taking that day, Cindy. I'm just telling you ahead of time. Its next session is 9/26/24 at 1 p.m. At that time, we should have a final rule. And I want to encourage everybody, please, 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 it'll be in the newsletter and in our emails probably 17 times before the end of the period of time. And I say 17, it's probably 70 times that the deadline for commenting on the proposed PPS rule is August 26th. August 26th. Encourage as many people as possible to write a comment. Cindy,
I would also say, Sherry, to be on the lookout for unfiltered discussions from Sherry and myself about some of the things in that proposed rule, especially a significant call to action to comment about removing the restriction of if nursing is ordered, then they're compelled to be the ones to do the admission. No one is suggesting that this is going to mean we're going to make the therapist do all the admissions. It simply allows, as happened during the waiver period, your agency to decide who's available, who makes the most sense, and I think has a direct bearing on the timely initiation of care issues. So we're not just going to put it in the newsletter. We're going to have some interesting conversations, and that's why we're going the unfiltered route for that one about some of the things in that proposed rule. But we can get all upset and bent out of shape or apathetic if we don't respond. CMS always takes silence as agreement.
yes.
So if we don't agree, if we have concerns, motivating as many comments, especially from, as Sherry said, frontline clinicians, from patients, from as many people as possible is what moves the needle. A couple of comments from a professional group, they don't take that as seriously as they do when they see things en masse. So be on the lookout for them.
Just as a reminder, the generation that we're serving right now in home health was a generation that marched on Washington multiple times. So get them involved in what kind of care that they get in the home and what they can expect. I think it's super important, and it does resonate. I think patient comments resonate as much as any comment that goes in to CMS.
Mm-hmm.
So any other questions, please don't hesitate to reach out to us via the emails that are on the screen. And again, thank you for the 100 folks that signed up, the almost 300 that registered. We enjoy doing these Q&A, and I hope that you guys find benefit from it. And I want to thank everyone for attending.